Thank you. Scott, we've got about 10 questions if I read them out. So the first one is, when due for second-line treatment, do you again wait for the patient to warrant the treatment, or do you treat at first sight of it?
Yeah, sorry, I got lost in some of the things when I was talking about it before. So many things I would like to get over. You need treatment when you need treatment, but you can detect the disease far earlier. So all of the rules of what I'm saying to you, early stage disease, your body can happily live with CLL. So if you've had your first line treatment or your second line treatment or your third line treatment, your disease is knocked back, your body's working well, you don't need more treatment. We keep watching it until you do get to a stage, and then we treat it when you're symptomatic, okay? The only thing that has skewed that up at the moment is the fact that these new drugs like, I can say it again now, idelalisib or ibrutinib, they were licensed and approved for continuous treatment. So you basically took those until you either suffered side effects or the drug stopped working. So that's the only time in CLL, or many other diseases for that fact, where we've gone directly from one treatment to another to another. The rest of the time it's, here's your course of treatment, it's knocked everything back, we watch, then we've got to a stage we need treatment again, we treat again. The beauty of that is risk of treatment toxicity, poisonous effects while you're having the treatment, live your normal life. Risk of treatment-related toxicity reduces your life for a bit, back to normal life. That's what we're trying to get to. None of what I have talked to you is about the psychological support, getting your head around all of these things, living with, you walk into me and you say, oh, I'm having terrible sickness. I say to you, oh, well, what do you expect? You're having chemotherapy. But to you, that's friggin' miserable, I can't go anywhere, I can't do this. Different standards. So I often talk about in my clinic, somebody was asking me about, what's your nurse specialist for? Well, she's the good guy and I'm the bad guy. I say, get on with it. She says, oh, that's terrible, how can we support you to get on with this?
Thank you, Scott. The next one is, if you have a painful lymph node, albeit smaller than 5 centimetres, is removal advisable? Would there be any side effects?
So if lymph nodes, wherever they are, need treating, we don't tend to do chopping out locally to deal with it, because it's probably a marker that your disease is getting to a stage where the whole lot of it needs to be addressed. The obvious exception to that is if you are at the diagnostic stage, we often take out a lymph node to look at it underneath the microscope. If there is a local particular problem, we can sometimes consider radiotherapy within our armament of things, because these diseases are very sensitive to radiotherapy, and it's a much more tolerable short treatment. But generally, surgery we don't advocate, because it causes you damage, takes quite a long time to recover from, and usually, as I say, it's a marker that your disease is needing treatment in other ways. Okay.
And then with the new treatments, is there any benefit in treating on diagnosis rather than watch and wait?
So, about to be addressed, the Germans are running a trial. So, lenalidomide drug that I was just talking about, we set up a trial where we were going to look at using that. So, sorry, if I go back a little bit, in the 80s, I think it was, the Germans did trials of giving chlorambucil treatment to patients who were asymptomatic early stage disease, and what they showed was no improvements in outcome, only poisonous effect from the treatment. Similar things were tried with fludarabine when that came along, again, same outcome. So that's where the belief comes that it's not worth treating the CLL until it gets to a stage of compromise, and that's because we are not curing the disease with these treatments, okay? As we get newer treatments, if they're less toxic, then maybe will we get to a stage where there's a better balance and it can delay things. So lenalidomide we were going to try, and then we got the reports through about the secondary cancer. So the difficulty is how do you capture both the early and the late complications of any treatment? So it might appear initially that you've got benefit because you've delayed needing a much more toxic therapy for a while, but then if 10% of people get a secondary cancer, is that a good balance? So again, we'll only know these things through trials. The Germans have set up a trial to look at giving ibrutinib for people with what's defined at the moment as not needing treatment, and we'll wait to see what the outcomes are of that. But I suspect, from what we know with everything else, ibrutinib does not clear the disease. So I think we will probably have to wait until we've got a good measure of what it takes to cure CLL, and then we might be able to transfer that earlier. That's my suspicion.
Thank you, Scott. Next one is, can mutational status change, for example, after treatment?
So evolution of disease is why we believe the traditional thing is with each line of therapy, the disease tends to not respond for as long. And we believe that is because it is evolving in ways and becoming more aggressive with time. So yes, all of that is possible.
Thank you. Next is, what is the difference between SLL and CLL?
So I think we went through that, didn't we? So the only difference between CLL and SLL is whether or not the disease is detectable in the blood. In all other ways, they're exactly the same thing.
Thank you. And how broadly shared are best practices across the UK?
We try very hard, but ultimately we are at the limits of how interested clinicians are. I think you're very lucky in general within the North East that the standard of healthcare is very high. We also try to standardise treatments through these things called multidisciplinary meetings. So pretty much every team should meet as a group, and treatment decisions about patients should be discussed, and there should be relevant experts in that room to guide what is the most appropriate thing. Obviously, the level of what you call expert, I remember once having it described to me is what makes an expert, and from the discussions in the room, nobody could truly agree upon that. So there is only me in the North East who sits on the many of the CLL boards, but CLL is a common disease, so quite a lot of the clinicians around the place will have their own experience, and we have lots of meetings to try and educate about all the latest breakthroughs. So we try very hard, and I think it's partly our responsibility to try and educate, but there is always an advantage that if patients join associations like this and are aware of things going on, you are perfectly entitled to ask clinicians, what's going on. The NHS is really trying to advocate trials. We should all be trying to offer trials where possible, and certainly trials should be discussed as part of your treatment options, and whether there are trials available and what you're willing to do to take part in them. They're not available everywhere. So I think the answer to that is it's a two-way boat to make sure that you get what's right for you.
Two final questions, Scott. The first one is, you mentioned treatment of CLL and survival rates, but it's also said that most people die with CLL, not from CLL. So what are these people who don't survive dying from? And as it's mainly older people, what would they have died anyway?
So my view of that would be, it all depends upon how data is recorded, and then you are very much at the mercy of how good your data is. So the classic example that I always give to this is, there used to be a belief that there was no lymphoma in Africa, okay? And so I went out to Africa and they said, why do you not see lymphoma? You must get people with swollen glands. And they said, if we see somebody with swollen glands, it's TB. And they say, well, how do you know it's TB? And they say, because they've got swollen glands. Do you ever chop it out and do you put it under a microscope to confirm that it's TB or whether it could be lymphoma or something? And he said, no, we give them antibiotics, but they often don't do well. So, you know, that is data. I've already said to you that if you look at CLL in different areas and you look at tables of statistics, there is variability in incidence rates, but we don't truly believe that. We haven't got obvious different racial presentations in our own practices, so I think that's more data recording. I think there are loads and loads and loads of people who die from other things, that lovely word, natural causes, or other problems. You know, people who die from leukemia often don't die from the leukemia itself, they die from infection complications. Sometimes the CLL changes into more aggressive disease, and it's those sort of problems that cause the trouble. But I don't believe that most people with asymptomatic CLL die from their CLL. That's not what the statistics suggest.
And finally, is IVIG considered watch and wait?
Yes, IVIG is a supportive care. As far as we know, it has no direct treatment effect on the CLL. It is making up for the deficiency of the immune system caused by the CLL, if that makes sense.
Okay. Can I just ask us to give another round of applause and thank you very much to Scott for a great presentation.